Hello everyone, today I'm going to show you about abnormal X-ray. This is a lecture which is followed by the normal reading check X-ray or how to interpret check X-ray. This is the lecture of practice. So we have three objectives. First one is we review about step on approach to the check X-ray. Review about radio density and X-ray cases. So this is the tip where we have to use or to remember before starting to interpret it X-ray. In order do not to miss any finding. So the first one is T. I mean technical. We have to see is it the right patient, good exposure, any rotation, good expansion, is it a PA or AP projection. So how to assess the rotation? We use the alignment of the spinal process to compare the distance between both proximal clavicle. And the second step, we have to look for the abnormal area like deviation track here. Is it in the central and the angle of the cardinal, any medical equipment or foreign body at the cardinal level, and a or the tip of each tube, something like that. And the third step is we have to look for B is bone. First of all, we count the rib anterior is 60 and posterior is 10, and check our bone for lucency and opacity, check vertebral body. And number 4 is step for cardiac assessment. We have to assess heart size, ciliate size, and the size of mediastinum. And the fifth step is diaphragm assessment. You know, the right side is usually higher than the left in the normal, and we have to check air below the diaphragm, gastric tube, costophrenic and cardiophrenic angle. And the sixth step, we have to assess about the lung field. Is it equal in capacity or lung volume? And any medical equipment or something like that. And the last one is the seventh step is we check for soft tissue minority. And we already remember about the high density of uh, radio in the radiograph. So the first one is ANS, blackout, fat, gray, and soft tissue is light gray, bone is white, and metal is whiter. And here is the first case. The reason why this patient took chest X-ray because of the clinical concern about any abnormal bone growth of the left scapula, something like bone cyst. So let's see the chest X-ray. The clinical concern on the left clavicle, so we can jump to that. But before of this, we have to follow about the TABCDES. So the abnormal is in the B. We can see the palm on the lower at the lower margin of the left scapula with this well defined, and we can see the continuous the midline from the mother bone to the daughter bone. So this is probably a benign lesion that we call osteochondroma. So osteochondroma can be either sessile or pedunculated. It is seen in the metaphyseal region typical projecting away from the epiphysis, having continuous medullary cavity with the parent bone. And the common lesion for the long bone. And the next case is patient still desaturation on CPAP 5 cm, FiO2 30%, and Ranson is clear. So the judge took to rule out pneumonia or any lung collapse. So we use the same approach, T, A, B, C, D, E, S. So what we found here is a problem at the T and A because of rotation, and we see the abnormality in the A. We concerns about cardiomegaly. So in order to understand what is the problem for the heart, we have to check by heart ultrasound. In the next case, patient come to hospital because of fever, cough, dyspnea for 3 days, and we hear a crack call in bilaterally in the chest. So the clinical took X-ray because of concern pneumonia. So this is X-ray confirmed pneumonia. Before the answer, we have to go through from A, T, A, B, C, D, E, S. So the problem is we see the lung marking is increase both lung volume and flatten diaphragm and periobronchial coughing, and there is no any definite consolidation in both lung, and heart is normal size or not intact. So this is more likely the case of bronchiolitis. So what we can find in the X-ray to confirm it is acute bronchiolitis. So in acute case, it may be present as normal in the chest X-ray, and the normal to increase lung volume, nodular or reticular nodular opacity we can find. We can see the bronchial wall thickening or peribronchial coughing. But in a chronic case, non-TB and Pseudomonas, you can see reticular nodular opacity. In the tuberculosis and cavity non-TB, it usually happens in the envelope cavitary nodule, mass or consolidation. Let's see the next case. It is the same patient, but right now this patient got intubation. So we use same approach to check. So what we can see is the abnormal in the Airway, we see the tip of each tube is at the coronal level, and one more thing, the abnormality in the E. You can see the abnormal opacity in both lung with lost lung volume. So this is indicate that the atelectasis happened after intubation. And one more thing, we can see the tip of feeding tube probably is in the stomach. And this is another case, can be fever, cough, dyspnea, or concern about pneumonia. Is it pneumonia for this case of cough? We have to use the approach from T, A, B, C, D, E, S. So the problem is more likely happen the abnormal in the E. We can see the increased host lung marking with bronchial wall thickening, and there is no any definite opacity in both lungs. So this is more likely acute bronchiolitis. Another case also can be fever, cough, and dyspnea. Concern we have to differentiate between pneumonia and bronchiolitis. So we use same approach to see the abnormality is in the again in the E. We see this opacity in both lung field with low lung volume, and we see some increasing of the lung marking. So this is the bronchitis with complication of metastasis in both lung. Again, this patient is fever, cough, dyspnea, lung cough bilateral, and the clinician concerned about pneumonia versus bronchiolitis. But see, this patient is come to ICU, so we have to read clearly about this chest X-ray, and the problem is also happening in the T because of rotation and the E. So what happened in the E? First of all, we see the lead to be prominent lung volume in both lung field, but if we compare the opacity of the in the opposite of both lung, we can see it's more prominent in the right upper lobe. So this is the right upper lobe pneumonia. So how to assess pneumonia in chest X-ray? First of all, we have to find the airspace classification. That means the filling of the alveoli with infectious material at first, initially probably patchy as the recent case, and then become confluent as infections develop. And the second point, we have to look for the air bronchogram, where it happened because of the air-filled bronchi running through past-filled alveoli. And the last one, we have to look for the complication of the pneumonia, like pleural collection, cavitation. Another case is COVID fever, cough, dyspnea, and lung wheezing. So the clinician concerned about this. So what we can find here, we can see the abnormality in the P, where there is increasing the lung marking and probably there is a possible opacity in the alignment below, but it's more likely this is the peribronchial wall thickening, where we can call peribronchial cupping and some hair dripping in both lung base, evident by the blackouts compared to another lung field region. So this is more likely reactive airway disease. So what we can see in the chest X-ray for reactive airway disease. So first of all, we have to look for the peribronchial thickening, where it is a primary lobar or segmental bronchi, while adult may have bronchi on end visible is in the highland. Children usually do. Peribronchial thickening also produce tram tract like linear density in the lung from bronchi visualized in profile. And the second, we have to look for the hyperinflation of the lungs. And the last one, we have to look for the nucleic acid from mucus plug. Next case is the case of cough and hypersecretion. The clinician concerned about bronchopneumonia. To me, these images look for very dirty chest, where we can see is the abdomen mostly happen in the E. So the lung field is very thin in both lungs, but pronounced in the right lungs with increased lung marking in both lung field. And we can see the confluent opacity more pronounced in the right middle zone. And also we can see the flattened both hemidiaphragm and small or sound hair draping mostly in the left lower lobe or left wing base. So this is the finding confirmed to the bronchopneumonia in clinical setting. So what we can find for bronchopneumonia in chest X-ray, so we can see it's multiple small nodule or reticular nodule opacity, patchy and or confluent opacity, where represent area of the lung where there are patch of inflammation separated by normal bronchitis. The next case is come with Gajah murmur and lung clear, concerned about valvular function. So when we look quickly, we I feel that the head is a little bit increased in size, but when we measure, it is just in normal upper limit size. But in the E, we can see increased lung marking, and we can see the dot wide out, and the diameter is larger than the adjacent bronchi. So this is more likely indicate for the overload of the fluid in the lung in case of cardiac abnormality. So this is we call pulmonary flatura. So what we can find the pulmonary flatura in the chest X-ray. First of all, we can see the prominent pulmonary vasculature with pulmonary vessels are dilated and torsions extending further into the peripheral one sets of the lung. Diameter of a pulmonary artery is greater than the accompanying bronchus. Second is this increased size and number of hilar pulmonary artery. The 3, 5, and on should be seen. Diameter of the right descending pulmonary artery is bigger than the diameter of the trachea. And the third is cardiomegaly may be greater. In the next case, newborn came to hospital due to dyspnea, crackle, tiredness in the left chest, concern of pneumonia with pleural effusion. But the finding in chest ray is different from what we concern. So we can see is the then opacity with defined shape and continuous bubble from the abdomen into the left hemimedulla where we cannot find the definite diaphragm. So this is the case more likely indicate for diaphragmatic eventration with mediastinal shift to the right. So in the chest X-ray, we have to some to find some indication for congenital diaphragmatic hernia like initially hemimedulla may be appear opaque because loop are fluid filled. After that, we can see some paucity of bowel gas beneath the diaphragm. Once air swallowing begins, multiple lucency contained within bowels are seen, and patient develop the respiratory stress with increase may be increased because of the intestine occupy more space in the chest. And we can find some loop may remain fluid-filled, just not safe to the opposite size relative opacity of gas in the abdomen, scalp, or abdomen. If soft, if stomach remain in the abdomen, more central located than normal. Contrast through an empty tube is diagnosed. And this is the case of 8-month-old boy, skinny, dyspnea. We concern this dextrocardia, but of course it's not. It is abnormal heart sounds in the right side because of the occupied bowel loop in the left hemimedulla, but we can find definitely diaphragm. It's very high level compared to the right side. So this is more likely the case of diaphragmatic eventration. So what we can find the eventration in the chest X-ray. So eventration elevation of the affected portion of the diaphragm is usually seen as a smooth arm, while the remainder of the hemithorax contour is normal. The frontal X-ray may show a double diaphragmatic contour which is easily confirmed on the lateral projection. And this is again the case of newborn premature with gestational age 34 weeks, fast breathing and apnea sometimes. Be concerned about age and bleed. So the chest ratio very wide now in both lung fields. the abnormal of E, and we can see granular opacity along with a bronchogram. So a story, clinical, and the X-ray finding confirm about the HMD. So in the chest X-ray, we have to find some indication for HMD like diffuse ground glass classification of both lung-field with air bronchogram and hypoaeration. Hypoaeration from loss of lung volume may be corrected by respiratory therapy. And we can see the fine granular pattern, prominent air bronchogram, bilateral and symmetrical distribution disease. So this is the known case of HMD, but developed to dyspnea, but no desaturation, loss, loss lung volume, and rural pneumothorax. So after intubation, the, the chest X-ray appear mixed granular opacity and tiny lucente nodule, and later on developed into the pneumothorax. And this is the case of PIE. We call pulmonary interstitial emphysema. So what we can find the pulmonary interstitial emphysema in chest X-ray. First of all, we have to look for cystic or linear radiolucency in the interstitium radiating from the ileum. Affected segment is often hyperspanic and static in volume on multiple radiograms. Pneumothorax, pneumomediastinum of pneumopericardium. In supine patients, pneumomediastinum is evident by the sharp mediastinum sign. The heart tends to get smaller as intrathoracic pressure increases and the size diminishes venous return into the chest. Attention. We have to remember that clinical and chest X-rays should go together like husband and wife, and imaging diagnosis is the result of like a child. Thank you.